Good afternoon, evening, or morning, depending on where you are. Thank you for joining us for this plenary session entitled Current Social Crises and Sexually Transmitted Infections, Incarceration and Drug Use. My name is Kyle Bernstein. I am the branch chief for the Epidemiology and Statistics branch with the Division of STD Prevention here at CDC, and I will be moderating the session today. We have two excellent speakers, and I don't want to take up any more of their time, so I will get us started and begin by introducing Dr. Kim Blankenship. Dr. Blankenship is a professor of sociology and the founding director of the Center on Health Risk and Society at American University, and the Associate Dean of Research in American University's College of Arts and Sciences. She's also a co-director of the Developmental Core of the DC CFAR. Her research and publications focus on the social dimensions of health, particularly on how social structures, processes, and relations of inequalities based on race, class, and gender produce health, and on structural interventions to achieve health equity. STIs, HIV, and AIDS are her primary area of influence, and I'm going to pull up Dr. Blankenship's slides and turn the mic over to her.
Okay, thank you. So I'd like to start this presentation by saying something about the key framing concepts. Many of you are familiar with the language of social determinants of health, which is important for focusing our attention on how health is shaped by social factors, as distinct from behavioral and biomedical factors. But as operationalization often proceeds without explicitly theorizing about the social or how it operates to determine health. Instead, using an ecological approach, risk environments are characterized by various factors that are considered social simply because they're outside the individual or upstream from individual behaviors. These factors are analyzed as independent and operating along causal pathways to impact on individual behaviors, which are also viewed as independent of and predicted by these social factors. With this discussion today, I'm trying to move towards more of a social determination of health framing, which views the process of social determination as a dynamic one fundamentally shaped by underlying structures of power and oppression operating along race, ethnic, class, and gender lines. Also noteworthy in the framing is that I will focus on mass incarceration because in my view, it's a contemporary manifestation of these deeply rooted structures of inequality, and as such has profound implications for the determination of health, including STI. In fleshing out the process through which mass incarceration determines STI, we'll pay particular attention to the way it intersects with housing vulnerability. And finally, I'd like to suggest the importance of moving away from sexual risk behavior towards thinking about sexual practices, and towards recognizing the importance of locating the meaning of sexual practices within relationships that are themselves dynamically embedded within a social context characterized by mass incarceration and housing vulnerability. It's likely well known by this audience, but always worth repeating, that the US incarcerates more people and at a higher rate than any other country in the world. Even more important, while these rates have declined over the last 15 or so years, Blacks remain disproportionately likely to be incarcerated, making up 12% of the population, but 33% of those incarcerated in state and federal prisons. Incarceration statistics are just one indication of mass incarceration. I'm really using this language to convey a system that grew out of and continues to uphold racism, and though less discuss gender and class inequalities as well. The reach of the criminal justice system extends far beyond the individual experience of incarceration and includes community supervision, prisonization, hyper-policing and community surveillance, and criminalization, which is signified by the ways that individuals with a criminal record continue to be punished even after their sentences have been served. Indeed, sociologist and legal scholar George Lipsitz argues that through this process, a single instance of incarceration, no matter what the length, can become a lifetime sentence. And one of the places we see this is in the area of housing. There is a serious shortage of affordable rental housing in the United States. Currently, in no state in the country is full-time minimum wage work sufficient to rent an unsubsidized fair market two-bedroom unit. US subsidized housing policy represents the primary mechanism for addressing this by increasing access to affordable rental housing. And even so, fewer than 1 in 4 eligible households receives HUD assistance, either through public housing or housing vouchers. And waiting lists average 2 years nationally, but stretch to decades in some urban areas. This is compounded by numerous barriers specific to incarceration. For example, landlords and employers can conduct background checks, the results of which can be used to deny people with criminal justice histories leases or opportunities to earn income to support housing costs. Federal and state policies can consider incarceration history as grounding for exclusion from housing subsidies. So this problem with affordable and accessible housing is exacerbated for those with or involved with those who have a criminal justice history. And that has repercussions throughout the community. How does this relate to STI? Together, the research on the relationship of STI to incarceration, housing, or both tends to emphasize the effects of one or the other on the breakup of relationships and sexual networks and the greater likelihood of concurrent or multiple partnerships. What I'd like to do for the remainder of this presentation is provide you with 3 case studies that will take you into the lives of 3 different women from low-income, racially segregated neighborhoods that have been profoundly impacted by the many manifestations of mass incarceration. In so doing, I'd like to bring women's experience to the forefront, and rather than focusing on relationship instability and breakup, I'd like to convey to you the extraordinary efforts these women make to develop and maintain long-term committed relationships. These case studies provide an understanding of the complex ways that their relationships and subsequently their sexual practices in those relationships are determined by this context, and thereby further insight into how mass incarceration, particularly as it intersects with housing vulnerability, socially determines STI risks. So who are these women? They were recruited as part of the Justice, Housing, and Health Study, which is an NIMH-funded study to examine the intersections of mass incarceration, housing, and health, with a particular focus on sexual health. The baseline survey was comprised of 400 low-income residents of New Haven, half with recent incarceration histories, and 50 of those were purposely sampled and interviewed at 6-month intervals over the study period, from spring 2018 to May 2020. The 3 case studies I'll present were selected from the 14 women in this interview group who self-reported being HIV negative and having sex with men during the study period. The cases were selected to represent distinct efforts to develop, maintain, and in some cases successfully end relationships. The women's names you'll hear are pseudonyms that they chose. 2 of the women only referred to their partners as husbands, and so that's how I refer to them in the analysis. And when they did refer to a partner by name, I designated a pseudonym for the partner. So let's start with Lily. Lily is a 43-year-old African-American woman with 5 children. The father of her 3 youngest children is her husband. They'd been together for 17 years and married for 9. Lily and her husband had recently experienced a serious disruption in their relationship, leading to the separation of their households in different neighborhoods. Lily in one apartment and her husband and their 3 children in another. According to Lily, the separation of households occurred because during an argument, he said the wrong thing and I gave him a nice whack. He called the police, resulting in her incarceration for 3 weeks on a domestic violence charge before being released on 18 months of probation, a violation of which would send her back to prison. Though angry at her husband for what she saw as a betrayal, Lily worked to maintain their committed relationship while simultaneously ensuring her biggest priority, her children's welfare. As hard as it was, she sent them to live with him, thereby ensuring they were cared for while she was in prison, and after her release while she and her husband worked on their relationship. Lily's efforts to find a job over the study period were unsuccessful, as she had no recent work history and now had a criminal record. Despite many applications, she never made it past the background checks. Her precarious financial situation meant that she could not support her children economically, but she continued to care for them during the separation, and they spent almost every weekend and most of the summer with her. Though maintaining their relationship, the time Lily and her husband actually spent together was limited while she was on probation. She explains why she rarely went to his place. I was on probation, and remember, he was the victim, so if he triggered me off and I do something, he could call the cops. And who going to jail? Me. So that was a smart thing to do, stay away. At baseline, Lily indicates that in spite of the separation of households, she and her husband are in a committed relationship. The separation is meant to preserve that relationship. When asked, "You think you'll stay together?" she replies, Where he going? He ain't going nowhere all this time, and I ain't going nowhere all this time. Still, during the initial separation period, their limited time together meant they had sex infrequently. She believes he's okay with that, she said, because he's busy, he's working. Protecting herself from the possibility of incarceration by spending long periods of time away from her husband, Lily gives him free time he might not otherwise have. This doesn't mean he's involved with another woman, but it does raise that possibility. Yet when they resume more regular sexual activity after her probation ends, Lily indicates that they do not use condoms. I tell him to put on a condom, he'll really bug out. He'll look at me like that'd be an argument, or be thinking I'm sleeping with somebody else. You know how men think. And I would think that too if he was to say, I'm going to put on a condom. Though they face challenges as they deal with the consequences of her incarceration and as she protects herself from further involvement with the criminal justice system and seeks suitable and affordable housing for her whole family, Lily and her husband managed to maintain their committed relationship and protect their children's well-being. After her probation ended, they spent more time together, though the households had still not reunited by the study's end. Maya is a 43-year-old woman who identifies as racially mixed. At baseline, she is about 7 years into a relationship with a man she refers to as her second husband. He's a recovering addict, is disabled, and requires hemodialysis 3 days per week. Through much of the study period, Maya works to preserve her commitment to her husband, which includes a strong sense of responsibility for his health and well-being. But by the end, she has left him for an old boyfriend. Not long before she entered the study, Maya had been arrested on drug sales charges. She felt she received excessive attention from the police for selling drugs that she said were to a friend from her private stash. I mean, they treated me like I was the queen pin of the town. The whole police force came to take me out of my house. I'm a drug addict. I was just trying to make money to pay a bill. However minor Maya believed her infraction to be, the consequences of her incarceration for her well-being and her relationship were substantial. She struggled throughout the study with recovery, community supervision, housing, and employment challenges. After 2 months in prison awaiting sentencing and another 2 in a transitional treatment program, Maya accepted a judge's offer of release onto probation, saying her husband needed her to take his medicine properly and to go to dialysis regularly. When you get married, it's just you and your husband. It's like a bond. Even his family won't take care of him like I will. Still, any violation of probation, including failed drug tests, could send her back for 7 years. Maya's husband brought $850 in monthly disability benefits to their relationship. He also qualified for an apartment in a housing authority building in a suburb where they'd been living when she was arrested. But when she returned from prison, the housing authority insisted her husband remove her from the lease. He refused, and they were evicted. Unfortunately, his eligibility for housing was not transferable. For nearly a year, they moved around, essentially homeless. She's staying in sober houses and other programs or joining him on the couches of relatives and friends. Maya describes the frustrations of trying to coordinate a job search, a search for housing, the demands of probation, and the responsibilities of caring for her husband. In 3 months, she submitted 73 job applications, getting 12 first, but no second interviews, largely due to failing background checks. She eventually found a job at a cleaning company, but this made her housing search challenging in other ways. She told us, I have to take off work to find a house, but then I need to work to pay the rent. 9 months after her baseline interview, Maya found an apartment with a substantial security deposit and a high rent that reflected the landlord's willingness to ignore their eviction history. And she described extensive drug selling in the surrounding neighborhood, hardly ideal for recovering addicts. Still, she remained hopeful that they could make it work. But her efforts were interrupted when her husband went to the ER and ended up having heart surgery. Her caretaking and commitment to the relationship meant that she missed a promising second job interview and could not continue either her job search or her cleaning work. Unable to keep up the rent, the landlord agreed they could break the lease. Maya went to live with her aunt and he with his cousin. Maya insisted that her plan was to go back and stay with him. I'll never leave him, she said. I love him. And yet she also found herself wondering. He's like, just come stay here, and in 3 months, we'll save some money and we'll be able to get a place. But see, he's not looking at the whole thing. Like, okay, we saved money last time. Look how hard it was for us to even get somebody to show us an apartment. Maya does leave her husband. It starts when she encounters an old boyfriend, Curtis, that she left 18 years ago, but whom she refers to as the one that got away. Though initially presenting the start of the new relationship as an impulsive move to reconnect with a past love, in a later interview, she names her ex-husband's relapse and her love for him as a final factor in dissolution of their relationship. Curtis, with already proven feelings for her, signified a chance to try again in a new relationship. Despite the many challenges in maintaining their relationship, until Maya left her husband, she was deeply committed to it. They remained sexually active with one another during their time together. Me and him, we never use condoms, and we don't because we're monogamous. Yet in that same conversation, she also indicates that she suspects her husband was having sex with other women. He's a man, you know, men are simple. It's not rocket science. What you won't do, another woman will. Nevertheless, Maya describes their agreed upon rules. Do what you gotta do, make sure you put on a condom, and you know the rest of the rules. No penetration without a condom. Oral sex is all right. Because sex between her and her husband is embedded within a committed relationship, condoms are perceived as unnecessary. Sex with other partners, when following their agreed upon rules, does not threaten this relationship. Her relationship with Curtis quickly progressed towards one of commitment, developing with a similar emphasis on caretaking. Indeed, Curtis had serious COPD. With regard to sex, as their relationship work progressed, they abandoned condoms. Still, her last interview made clear that the work to develop their committed relationship was still ongoing. Less than a year after they got together, Maya, interpreting Curtis's lack of interest in sex as infidelity, though she did later learn that it was because of his worsening COPD, became distressed, relapsed, and failed her drug test. To avoid a possible 7 years in prison, she agreed to enter an inpatient program, even while acknowledging that doing so might jeopardize the progression of her relationship with Curtis. Reyna is a 43-year-old African-American woman who has been singularly responsible for the raising of her 5 children. Reyna has never been incarcerated. Over the study period, she juggles overlapping relationships as she works to determine if either of them has the potential to meet her ideal of what she calls a forever partner, an intellectual companion who provides interesting conversation, but also shares the pleasures of simple activities like bike rides and breakfast together. Trustworthiness, she says, including sexual monogamy, is also fundamental. Reyna's relationship work also involves ensuring her highest priority, her son's well-being. To this end, she works to preserve access to safe and affordable housing while successfully navigating the criminal justice and social service systems. Reyna has had a Section 8 housing voucher since she was 17. While giving her access to affordable housing, it has not always ensured her family's safety. At baseline, she's living with her boys in a relatively quiet New Haven neighborhood. The rocky road that brought her here included, in 2015, spending the holidays in a 90-day shelter where she and her children were temporarily relocated by Section 8's domestic violence services to protect them from retaliation when she rejected an offer to join a neighborhood gang. On the next Thanksgiving, soon after moving into a different apartment, she describes how her turkey basting is interrupted by a murder outside her kitchen door. I hear, no, no, pop, pop, pop. I was like, oh my God. And then I looked in my son's room because I thought maybe somebody shot in his window because they were right there. This time, Section 8 is less helpful, reviewing her record of domestic disturbances and complaints and suggesting she is the troublemaker, placing her in jeopardy of losing her voucher. When she involves legal aid, they allow her to keep the voucher, but not to break the lease to relocate. Along with gang violence and unresponsive landlords, Reyna also fights to protect her family from child welfare services. DCF took one of her sons for 3 months when she missed 3 doctor's appointments. She successfully represented herself in getting him back. When another son was injured by a classmate, Reyna called DCF to investigate the school, but they also investigated her. Not trusting the schools to protect her children, she's been homeschooling them ever since. Ultimately, Reyna dreams to escape the gaze of the social welfare system altogether and become a homeowner. She explains that Section 8 keeps her under a watchful gaze. They can look at anything that has to do with Reyna. I don't want to have to give them my social, my kids, birth certificate, my income. You have to give them all your life, your guts, your ribs, everything. While she struggles to make her life in New Haven, Reyna also longs for companionship. At baseline, she has just broken up with Randall, a man 10 years her junior who had spent much of their 2 years together in prison. During the study, Reyna and Randall got back together and broke up again multiple times. She said he was smart and she could talk with him about anything, but he had trouble finding work, and when he did, it was low-paid, short-lived, or inconvenient. Most damaging were 2 acts that broke her trust. First, she discovered that, she said, he was sleeping with a girl around the corner. I knew he had a friend around the corner, but he didn't make it seem like it was a relationship. But I began to realize in our relationship he was creating arguments and leaving easy with no problem. So she investigated and confirmed her suspicions. In addition, he slashed her tires in retaliation for breaking up with him. After you stabbed my tires, there's no more trust there. I would never put money in a bank with you. You might get upset and take it all. Randall's involvement with the criminal justice system clearly shaped the possibilities for their relationship, in spite of their efforts. His record made it difficult to get the good jobs that Reyna wanted for him and sent him to his existing networks in the illegal economy to make money. He likely did not qualify for housing assistance, but Reyna had no intention of jeopardizing her family's housing by putting him on her lease or even letting him live with her. She said he has to live somewhere else. So with limited access to independent and affordable housing of his own, Randall moved among the homes of women who did have such access, further undermining the progress of their relationship work. In reflecting on the relationship in her last interview, Reyna captures the potential it held for her, as well as its ultimate ending. She said, "More than ever, I miss his smile. We were happy to be in each other's presence. Still," she conceded, "he's not as strong as I am. He's like one of my sons, someone I have to encourage and uplift. I'm looking at him like, you didn't come along. You were supposed to jump along with me. You were supposed to be by my side, not in front of me, not behind me." She spoke with far less regret when reflecting on her relationship with Chilton, who she met soon after confronting Randall over the tire slashing. Initially, she describes him as a sweetheart and someone who she enjoys sex with, but she also complains that he has no personality, no talk, and acts strangely when he stays at her house, hoarding his own food and obsessing when she moves his things. She once angrily walked him out of her house. "The time I allow you to have, you appreciate it. I allow you in my space, but when you do that in my space, bye." Though coming to recognize that Chilton is not a forever partner, Reyna continues to allow him to spend nights, saying, "He would give me money. That's the only reason why I made it." Reyna is aware that having sex with multiple men can put women at risk, and she indicates using condoms early in her relationship with both men. But over time, condom use interfered with her quest for a forever partner. When angry with Randall, she withheld sex altogether rather than insist on a condom. Similarly, as she sought to determine whether Chilton could be a long-term partner, she let condoms go, and once it became clear he couldn't, the precedent had been established. Still, Reyna draws clear boundaries around who she will sleep with. When Chilton once pressed her on whether she was sleeping with other men, she snapped, "What, if I let myself go and let every man I met talk to me and pump on me, I wouldn't even be a good person, would I? I wouldn't be worthy of having sex today now, would I?" Reyna distinguishes herself from those who may need to worry about their sexual health. Whoops. Sorry. These three narratives illustrate how women's relationship work is shaped in a context characterized by the many manifestations of mass incarceration and the ever-present surveillance state as they intersect with housing vulnerabilities. They also suggest how the meanings of sexual practices are constructed in this context within relationships. In so doing, they direct attention away from sexual risk as contained in individual behaviors and towards understanding social context as risk. Lily's case study demonstrates the challenges of maintaining a long-term committed partnership during a household separation, one perceived as resulting from a relationship betrayal. Lily and her husband's relative success is likely built on their respective access to affordable housing, she with a voucher and he with a long-time job, perhaps reflecting his very limited interaction with the criminal justice system. These circumstances are relatively rare in the context in which they live, and theirs is a fragile security. The household is not reunited, and Lily's economic situation became even more threatened by the last end of the study when her oldest son went back to prison. She relies on 17 years of their relationship, with neither having anywhere to go, to presume monogamy. To introduce condoms into this situation, given the meaning both she and her husband give them, is to threaten both the trust built through their relationship work and subsequently their children's well-being. Like Lily, Maya worked to preserve her committed relationship. That work simultaneously involves caring for her husband's health. She and her husband have far fewer resources than Lily and hers to facilitate this work. Whereas the fracture of Lily's household resulted from an act of betrayal, for Maya, it was her and her husband's commitment to each other that changed their living arrangements. Yet their relationship work, along with searching for housing and employment, seems undermined at every turn. Likely recognizing the fragility of their situation, they establish rules about how to navigate sex with other partners while leaving their commitment to each other intact. But in spite of their foresight and efforts, their relationship ends and she embarks on a new relationship with a past love. While Maya's overlapping relationships and non-condom use may increase her sexual risk, they also signify her dogged pursuit of a committed monogamous partnership meant to protect both her and her husband's health and well-being. Reyna worked to establish a committed relationship with Randall and for a time to determine if Chilton had a potential to be such a partner. She's made a life for herself and her children that revolves around maintaining a safe and stable household and avoiding the gaze of the criminal justice and social service systems. Keenly aware and fiercely protective of this fragile stability, she restricts both men's access to her home. They can stay, but they need somewhere else to live. But where do they live in a context where their access to affordable housing is shaped by their incarceration history? Furthermore, that access is gendered in these neighborhoods. Women are more likely than men to have housing, in part because they're caretakers of children, and less likely than men to have an incarceration history. Reyna wants someone who is her equal, a trustworthy companion and a provider. Yet in this context, it is hard for Randall to meet her standards. Condoms are a part of their work of establishing and developing her relationships. Continuing to insist on their use over time is both a sign that the relationship may not be progressing and a barrier to its further progression. Though generally aware of the risks associated with unprotected sex with multiple partners, Reyna's self-image and history with these two men mean for her that she's not really having risky sex with multiple partners. Still, she indicates that she gets tested for STIs and for HIV as part of her annual doctor visits. Testing negative confirms her sense that she's not at risk. I hope this effort to detail these women's relationship work and related challenges suggests both that their relationship work is the work of STI prevention and how life in low-income, racially segregated New Haven neighborhoods is their sexual risk. This has two critical implications for addressing this risk. First, interventions to change individual behaviors must recognize how the meaning of those behaviors is constructed within relationships that are, in turn, embedded in specific social contexts. Prevention interventions are also part of this context and have implications for the meaning given to relationships. Second, however well-informed of social meanings and contexts such individually focused interventions are, they are not likely to eliminate race, gender, and class inequities in STI. This goal will require a focus on the systems that underlie those inequities and ultimately the creation of new contexts that ensure health for all. We focused on mass incarceration as a contemporary manifestation of more deeply rooted systems of inequality, as well as its intersection with housing vulnerabilities. They operate via policies, programs, practices, and decisions that can be changed. For example, federal policies restrict access to housing based on criminal justice history. Landlords and employers use background checks to determine access to housing and jobs. Zoning policies contribute to neighborhood segregation. Child welfare services prioritize investigation of mothers over the word of school administrators. Community resources are spent on promoting safety through the surveilling of low-income neighborhoods, patrolling of schools, and incarcerating of individuals for low-level drug crimes. But efforts to reform these and other relevant policies must also consciously acknowledge and challenge how they represent more deeply rooted systems that reflect and protect race, class, and gender interests and power. The work of reducing or eliminating STI transmission generally and inequities in transmission in particular is inextricably linked to the work of confronting these systems. Thank you.
Thank you, Dr. Blankenship. I'm sure everyone is applauding loudly in their homes on mute. I'd like to take a moment to introduce our next presenter. Dr. Stephanie Strathdee is an infectious disease epidemiologist who is the Associate Dean of Global Health Sciences and the Harold Simon Professor of Medicine at the University of California, San Diego, where she co-directs the Center for Innovative Phage Applications and Therapeutics, known as IPATH. She has studied the syndemics of HIV, viral hepatitis, TB, and STIs on the US-Mexico border for 15 years. She and her husband recently co-authored a memoir, The Perfect Predator, a scientist's race to save her husband from a deadly superbug. Dr. Strathdee was named one of Time magazine's most influential people in healthcare in 2018. I will pass it over to Dr. Strathdee for her presentation.
Thanks very much, Kyle, and it's a great honor to be able to present to you and your audience virtually, and also to follow my esteemed colleague, Dr. Blankenship, in her presentation, which sets a context for my presentation, which is really about the collateral damage that the U.S. opioid crisis has had on sexually transmitted infections in the U.S. and continues to have. So it's not a surprise to anybody that before COVID-19 burst on the scene, that the opioid crisis has been one of the most important public health emergencies of the last 20 years. This slide just shows some of the headlines. And the increased availability of prescription opiates, then cheap heroin and methamphetamine and fentanyl have contributed to a dramatic rise not only in overdose deaths, but also outbreaks of HIV and viral hepatitis, especially hepatitis C, among people who inject drugs and their sexual partners, not just in urban centers like we saw before, but also in rural and suburban regions, especially those that are socially disadvantaged. Now, less attention has been paid to the collateral damage with sexually transmitted infections. Now, some of the most important work that has been conducted in this area, and there's actually not a whole lot of research, but the most important work has actually been done by colleagues at CDC. This is a slide that shows that, an ecological analysis by Abera and colleagues showing a positive ecological association between county-level opioid prescribing rates and county-level rates of reported gonorrhea cases among men from 2010 to 2015, which corresponds to the period that we know that the opioid crisis was occurring. Similarly, at this conference, Copen and colleagues are presenting a poster showing higher scores on a social vulnerability index that are associated with higher rates of gonorrhea and chlamydia. And these associations are very telling. Now, if we drill down a little bit and we look at the geographic distribution of overdose mortality over the last 17 years, starting in 1999, this slide shows that there's been a changing pattern. Now, in blue are the counties that have the lowest opioid mortality rates, and in the darkest red color are the counties that have the highest opioid mortality rates at 30 per 100,000 or more. And you can see that over time, we start to see a lot more red dots. And these are concentrated in the West, in the Midwest, in the South, and also in the Appalachian region, which is one of the poorest regions of the United States. Now, what was interesting to me as I prepared this presentation is that when I looked at the geographic distribution of primary and secondary syphilis, according to CDC statistics, you can see that although it's not a perfect overlap, that I actually thought I was looking at overdose death rates in these counties. There's a preponderance of cases in the West, in the Midwest, and in the South. And what this suggested to me was that we're really looking at syndemics. Now, it wasn't until about 2019 that an MMWR reported by Sarah Kidd and colleagues from CDC indicated that there was a relationship between not just the opioid epidemic, but increasing rates of methamphetamine use and injection drug use among women and men, mostly heterosexuals, from 2013 to 2018. And the press picked this up. So let's look at these patterns a little bit here. During 2014 to 2018, the proportion of primary and secondary syphilis cases that reported injection drug use within the last 12 months doubled among women, and men having sex with women decreased slightly among those who were MSM. And in such cases, it's not the injection drug use itself, obviously, that's causing the sexually transmitted infection. It's high-risk sexual behaviors and processes, as Dr. Blankenship would say. And in the context of this, also, substance users are having sex with other substance users, and often without condoms. Sorry, I'm just trying to move my slides. There we go. And if we look now at the proportion of primary and secondary syphilis cases that report heroin use and injection drug use and methamphetamine use, you see that this is among men having sex with women, that there's been an increase in all of these categories, quite strikingly, and in many cases a doubling. Most importantly is the trend with methamphetamine. Now, why is this an issue? Well, it actually mirrors what we're seeing at a national level, because during 2015 to 2018, a recent paper was reported that 1.6 million US adults reported using methamphetamine in the last year. 22% injected it, and about half qualified for a methamphetamine use disorder. Now, another concerning trend is that there's been increasing reports of opioid users using methamphetamine across the US. So this is polydrug use, up from 19% in 2011 to 34% in 2017. Now, why is this an issue? Well, methamphetamine in particular has both a direct effect on sexual behaviors and an indirect effect on sexual behaviors. What do I mean by that? Well, first, meth is associated with increased impulsivity and sexual compulsivity. It's known as one of the drugs that's involved in chemsex, which is seeking out drugs for an enhancement during sex, especially among men having sex with men, and among whom it's been associated with binging, sex marathons, and barebacking. It's also a stimulant, so it keeps people awake. And as a result of this, it's often sought out by sex workers who trade sex for money to buy meth, trade sex for meth directly, or use meth with their clients. Now, the western part of the United States was the region that was hardest hit by methamphetamine, and so they have some of the best data. Now, this is a slide showing Los Angeles County drug treatment programs, and it was shown that among those who reported meth use as their primary drug of abuse at entry, 59% reported chemsex. And almost 7% had any sexually transmitted infection, most often chlamydia. Now, the concerns about meth and its health and social consequences have led to a number of public health campaigns, largely in the gay and bisexual community. These are three different dramatic campaigns that show images that have appeared to have an impact. Because if you look now at the reported rates of drug use among men who have sex with men who have been diagnosed with primary and secondary syphilis, you see that there's been a stabilization since about 2015. Even though methamphetamine use is high, it's been stable. And sex with a person who injects drugs is actually declined somewhat. But this is not a pattern that we see uniformly distributed across the country. In 2018, we see declines in the proportion of MSM, primary and secondary syphilis cases that report meth use in the West and the Midwest, which is bumped around a little bit, but an increase is observed in the Northeast. And so this trend bears watching. Now, it's important to realize that many substance users don't just use one drug. We tend to siloize people and categorize them as a heroin user versus a methamphetamine user. Increasingly, we're starting to see people are using multiple substances, even in one sitting, or to use one drug to bring them down or up when the other one is waning off. And this slide is showing polydrug use patterns from West Virginia, which is the only state in the United States that is solely located in Appalachian region. And you'll see that among overdose deaths, that fentanyl and methamphetamine and heroin have all been implicated. Now, why worry about fentanyl? Now, clearly, methamphetamine as a stimulant and cocaine as a stimulant are usually the most drugs that we associate with high-risk sexual behavior. But fentanyl is something that I think should be on our radar because it has very addictive properties. It's much more addictive than heroin or even morphine. And these addictive properties lead people to do desperate things to get their money to buy more drugs. And that leads to the sex trade. So now if we look for among women, we see that the relationship between drug use and the sex trade and sexually transmitted infections is a special concern. And this is given that we see rising rates of heroin use, injection drug use, sex with a person who injects drugs, and methamphetamine use. Very startling trends among women with primary and secondary syphilis in the US over the last 4 years. And according to the National Health Behavior Surveillance System, that is a network of studies around the US, 39% of female people who inject drugs report sex trade in the previous year. So this is of grave concern. Now, again, these trends are not uniform across the country. In 2018, the proportion of women with primary and secondary syphilis that reported sex with a person who injects drugs is highest in the West, but it increased sharply in the Midwest and the Northeast. And in terms of race and ethnicity, non-whites bear a disproportionate burden of reported primary and secondary syphilis cases relative to whites. In 2018, the highest rates among men were among Blacks and Native Hawaiian and other Pacific Islanders. But among women, the highest rates were among American Indian and Alaskan Natives and Blacks. Now, when we see increasing rates of primary and secondary syphilis among women, we have to be really concerned that we're going to see parallel increases in congenital syphilis. And that, unfortunately, is the case. This is a slide that shows that following declines in primary and secondary syphilis and congenital syphilis between 2009 and 2012, we started to see an increase in both from 2014 through 2018. And again, this is coinciding with the period when the opioid crisis was really taking off. Now, during 2018, we saw over 1,300 cases of congenital syphilis reported in the US compared to 73 cases during 2017. So this is a very concerning problem, and it's also reflective of poor access to care, especially reproductive health care. This is a slide that shows the geographic distribution of congenital syphilis, courtesy of Kendrick Huff and colleagues from CDC. They also developed a predictive algorithm to identify some of the counties where they expected to see congenital syphilis. The counties that are in blue are where actual cases occurred, but their model predicted that surrounding these regions, which you see in red, there weren't congenital syphilis cases there, but they predict seeing them. And if this trend bears, if it comes true in the future, we're going to see a lot more congenital syphilis cases. These are the regions that we need to be placing interventions. Now, in terms of congenital syphilis cases and its relationship with race and ethnicity, you see that for all race and ethnicities in the United States, we've seen an increase, but the increase is most marked among Blacks and American Indians and Hispanics. So this is a reflection not only of untreated syphilis, and we've really, that we've let these women down, but we've also let down their babies. Now, there isn't a lot of research that's been done on substance use among American Indians and Alaskan Natives. This is one of the few studies we could find, but it shows that American Indian and Alaskan Natives have higher rates of prescription pain reliever use and methamphetamine use relative to the general U.S. population. And what this indicates is that we need to be paying attention to interventions both on and off reservations. Now, I've talked a lot about the problems. What do we do about interventions? This is a difficult population to deal with. They have multiple comorbidities, but I really think that we need to take a harm reduction approach that doesn't demand abstinence, because that isn't often achievable. Well, what do I mean by this? Well, here's an intervention that was developed by Kathy Reback and colleagues from UCLA. It's a theory-based text message intervention for stimulant-using men who have sex with men. It addresses 3 different domains: social support, health belief, and social cognition. And you'll see that the messages that they're using are really non-judgmental, they're pro-sex, and they have some humor. So, for example, dip it, don't stick it, or don't have an open sores relationship. And this intervention was developed along with a peer education educator model, and the text intervention was compared to self-monitoring intervention as well as a control. And the interventions, as shown in blue and in orange here, both of the interventions had showed a decline in meth use in the past 30 days among MSM, as well as sex while using meth in the past 30 days. So, and this really suggests that meth users have the ability to self-monitor if given the right skills, support, and education. Another intervention that I'd like to highlight is one that was developed by our own team here in San Diego by Tom Patterson, my husband, who developed what's called the fast lane intervention. And this was an intervention for high-risk methamphetamine users who were heterosexuals. And it's a motivational interviewing intervention that was also coupled with a maintenance or boosting component, because it was thought that we would need this to sustain their behavior change. And to our surprise, both interventions, the one that had maintenance and no maintenance, both had motivational interviewing, showed a decrease in terms of high-risk sexual behaviors compared to the control over time. And this suggests that it is possible to reduce high-risk sexual behavior in the context of ongoing meth use. But some of the reason that we've been focusing on behavioral interventions with methamphetamine users is because we haven't had a modality for medication-assisted treatment like we do with opioid use until recently. So Phil Coffin and colleagues just published a paper this year in JAMA Psychiatry on the influence of mirtazapine, which is an existing drug that's used to treat depression. And it was used in this case among MSM to see whether or not it would have an impact on their high-risk sexual behavior. And it did. It had a significant impact and showed not only declines in methamphetamine use, but also declines in the number of male partners, the number of episodes of condomless anal sex with serodiscordant partners, and the number of episodes of condomless sex that was receptive anal sex with serodiscordant partners. So the highest risk of sexual behaviors that we want to change. So this is actually really encouraging. Now, of course, we've had opioid use treatment in the form of methadone maintenance and buprenorphine maintenance for decades, but we've had major barriers to its scale up as well as retention. This on the left-hand side of the slide shows the treatment cascade for opioid users, considering that we have almost 2.5 million severely dependent opioid users in the United States. And in terms of the subsequent bars in this graph, you can see that the treatment gap in pink is expanding. There's only about 20% of all opioid users who are in treatment at any given time in the United States, and this is a real disgrace. In fact, the National Academies of Science, Engineering, and Medicine published a report earlier this year that I encourage you all to look at, and it identifies opportunities to improve not just treatment for opioid disorder, but also the infectious disease that come along with it. And it really speaks to the structural barriers that are facing these individuals when it comes to policies and programs and the logistics around access and retention to these programs. So I highly encourage it. It's an excellent report. I really hope that these recommendations are followed. Now, if we look now at just some of these barriers, I focus on women here because we've talked about not just syphilis, but also congenital syphilis. This is a slide that shows reproductive health needs among women receiving substance abuse treatment in Michigan. You can see here that over half of them reported having an unintended pregnancy. Over 70% of these reported substance use during pregnancy. Over half reported ever having a lifetime sexually transmitted infection, and over 40% currently were receiving contraception. And these are women of childbearing age, and over half had also had an abnormal pap smear. Now, when we drill down, this is the same group of colleagues who published this work on the types of barriers that women received or reported while they were in treatment, substance use stigma is a major barrier, as well as fear of child protective services. They're worried that their children are going to be taken away. Many of these women have children, and they also experience problems with cost and access to transportation. But beyond these macro level factors is the fact that controlling behavior of their partners can play a role, because many substance using women have partners who are also substance users, as Dr. Blankenship told in her vignettes. And the exposure of intimate partner violence also really drags these women down in terms of having the self-efficacy to take charge over their lives and to get treatment. 80% of these women said that they would prefer on-site sexual and reproductive health services while in treatment. And I understand that the CDC is engaged in some demonstration projects to do just that. So I'd just like to highlight one such a program called the Horizons program at the University of North Carolina. This is a substance use disorder treatment program for pregnant women or parenting women. It allows their children to be on site. It's not the only program like it in the US, but they are in the minority. This one in particular has a trauma-informed model and provides services for OBGYN care on site. And so I think it's a great example. Now, another touch point for accessing high-risk substance users who are prone to sexually transmitted infections are syringe exchange programs. And in the United States, a survey was done in 2013 of different syringe exchange programs around the US. And you can see here that the majority of them are providing HIV testing and counseling and referrals to drug treatment. But it's very concerning that only half of the urban programs, which are the most common ones, were providing STI screening. Very few were providing on-site treatment. And fewer of the programs in rural and suburban regions were providing any STI screening. And of course, this is where we're seeing the surge in opioid and methamphetamine use. So this is really where we need to be placing more attention. Of concern in 2020, since the COVID pandemic began, of 173 syringe exchange programs that were surveyed, 43% reported diminished services like STI testing due to COVID, and 25% had closed down. So we really need to ensure that we can enhance these programs because they're serving multiple reasons at this point. Now, in conclusion, I want to hopefully I've shown you that the U.S. opioid and methamphetamine epidemics are linked with high-risk sexual behaviors that elevate the risk of acquiring sexually transmitted infections, and that regions where we see changing patterns of drug use, such as increasing injection drug use and methamphetamine use, and I would argue fentanyl use, although we haven't got any data on it yet, should be targeted for STI screening. It really is a harbinger of what we're going to see. First, we often see hepatitis C rates increase, then HIV, and then it comes that we see our STIs. So we really need to be thinking about these as syndemics. We also need to take into account that these STIs are not geographically dispersed uniformly, and that we see major ethnic and racial disparities for both primary and secondary syphilis and congenital syphilis. And so we need to have targeted programs that take this cultural context into account. The touch points, I believe, are really in the criminal justice system, as Dr. Blankenship has described in her plenary, but also substance abuse treatment clinics. And I would include detox here, because often detoxes act as kind of a revolving door for substance users who are high risk. And then finally, syringe exchange programs, which I think have been underutilized in terms of targeting STI screening and treatment. And I would also argue that removing structural barriers to promote the uptake of medication-assisted treatment is likely to reduce not just opioid addiction, but also STI incidence. And if you believe me, then cooperation is needed across agencies and sectors to address structural drivers that impede access to STI testing and treatment, and provide integrated horizontal services and delivery models for STIs and related syndemics. So with that, I'd like to acknowledge Claire Bristow, who helped me prepare this presentation and who will be co-authoring a paper that we're going to write up on this, as well as numerous colleagues from the CDC. I want to give them a special shout out because CDC has been under an awful lot of strain lately, and you have some of the most brilliant minds, and you have my unwavering support. Thank you very much.
Thank you, Dr. Strathdee. Unfortunately, we do not have time for questions, but I would like you, if you have questions in the audience, please direct them to Drs. Blankenship and Strathdee via their contact information. I'd like to thank both of our presenters again. I think this was a really great session, and enjoy the rest of your morning, evening, or afternoon, depending on where you are. Thank you so much.